motivation and the endeavor, and it's really an exciting undertaking. So thank you for having me. Can you hear me?
Yes.
I'm going to be speaking this morning about bone marrow abnormalities on MRIs and an approach to analyzing them. Whether or not you're a musculoskeletal radiologist, if you're looking at MRIs, you've had the experience of looking at bone marrow and trying to decide if it's normal or abnormal. And alterations in bone marrow are common, and there's much normal variation, and there aren't a lot of distinguishing features that can help you decide whether something's normal or abnormal, whether it's benign or malignant. So today I'm going to be talking about an approach to analyzing that's based on understanding the normal and pathologic processes that happen in marrow and trying to use a systematic approach to looking at it. So we'll begin by talking about some basics related to bone marrow, talk about MR imaging techniques, talk a little bit about what this analytic approach might be, and look at some cases together. In terms of marrow basics, you probably know the medullary cavity has trabecular bone, and in and around that is the fatty marrow, the yellow marrow, and the hematopoietic cells, the red marrow, including red and white cells, platelets, and also including some fat within the red marrow. So if we're looking at MRI of normal fatty marrow, T1 weighted images, the fatty marrow is bright on T1 or hyperintense, high signal on T1 weighted images, and the fatty marrow is low signal on the fat saturated T2 weighted images or STIR images. That's what normal fatty marrow looks like. Erythropoietic marrow, more complicated. We see it here in the diathesis and metathesis, is isointense or slightly hyperintense to muscle on T1 weighted images, and hyperintense to fat on fat-saturated T2 weighted images. Now, normal red marrow tends to be slightly higher signal compared to normal muscle and compared to intervertebral disc on T1 weighted images because it invariably will include some fat, even though we call it red marrow. And contrast that with some process that's coming into the marrow and replacing marrow that has no fat within it. So when we look at an image like this, we see a focal island of red marrow and compare it to normal muscle. The red marrow tends to be a little bit brighter than muscle, and it may even have little islands of fat within it. Compare that to the tumor in the humerus here, which doesn't have any internal fat and which is lower signal than the surrounding muscle. When we're looking at the spine, we compare the marrow pattern to the intervertebral discs. And red marrow tends to be hyperintense to a disc on T1 weighted images, whereas abnormal marrow can fill up the vertebral body and be lower signal compared to the disc. There is a pitfall to that. Even though you have an abnormal process in the marrow, it may not be darker than muscle or intervertebral disc when it's just coming into the marrow, when there's still some normal marrow there, or when there's hemorrhage within it. That can raise the signal. One of the things we're seeing more and more of are using whole body MRI to do a marrow survey, and here are some examples of that. That gives us the advantage of seeing the entire marrow and getting a sense of tumor burden. One of the normal processes that you'll probably hear more about later today is the process of normal marrow conversion. So at birth, bone marrow is filled with predominantly hematopoietic marrow, and then over the period of maturation through adulthood, there's conversion to yellow fatty marrow. And it follows a very standard progression from red to yellow. So it's almost the entire marrow space is hematopoietic marrow in the beginning, and it converts regularly from distal, so the distal areas become fatty first, to proximal, from the appendicular skeleton to the axial skeleton, and then from the epiphysis to the diaphysis, and ultimately to the metaphysis. A very orderly pattern. And so that translates into something like this when we're looking at MR images. In a pediatric population, we see much more red marrow, but there's conversion to fatty marrow early in the epiphysis, but by adulthood, much of the marrow has converted over to fatty marrow. Differences between men and women, but the adult pattern is much more predominantly fatty marrow. The other process to be aware of is the possibility of marrow reconversion. And this is essentially a physiologic response to a demand for increased blood production, increased hematopoiesis. And the mature fatty marrow that the adult has already achieved then becomes replaced by hematopoietic red marrow. And this also follows an orderly sequence that's essentially the exact reverse of the original marrow conversion. So we see this process happening where the body has a demand for increased oxygen. For example, in obese females, in smokers, in anemias, people who live at high altitudes or high-performing athletes, in patients who are treated with marrow-stimulating medications, and also in disease processes where the normal marrow is being replaced or destroyed and the remaining marrow tries to compensate for it. What we should look for when we're seeing a normal adult pattern is normal fat in the epiphysis of the bones, of the long bones. This is actually some change related to arthritis, but you can see that the epiphysis has fatty marrow in it. And in this case, we know we're looking at an abnormal pattern because we see what looks like red marrow, but is actually tumor lymphoma extending into the epiphysis. The one exception to that, everything has an exception, and that's what keeps things interesting, is that you can see some retained red marrow in the subchondral portion of the epiphysis. For example, here in the proximal humerus or in the distal femur. But as you can see, most of the epiphysis has retained the adult pattern of fatty marrow. So that will allow as a normal variation. The other thing that is typically a feature, a normal feature, is that marrow tends to be symmetric from side to side. And that's a rule that's followed most of the time, except when there is an exception. And when there is an exception, you might have an area of focal red marrow in the bone that's not symmetric from side to side, and that can be very difficult to differentiate from malignancy. And so we're going to look at certain things. We're going to look at the density compared to muscle or disc. We're going to look for fat within the lesion, and we're going to use in and out of phase imaging, and in certain circumstances we might even use diffusion imaging. But here's what we're talking about. We're going to look at the density of this deposit in the marrow and see that it's hyperintense compared to normal muscle on T1 weighted images. And we can also see little islands of fat within the lesion. So those are clues that we're looking at normal focal red marrow. We can also use in and out of phase imaging, or also known as chemical shift or post-phase imaging, because we know that when fat and water are present in the same voxel, so-called microscopic fat, signal will decrease on the out-of-phase images. So in a benign process, in red marrow, we will have both water and fat in the same voxel, and signal will decrease on the out-of-phase image. When we have a malignant process, it's excluding the fat, and there's no fat in the voxel, and therefore it shouldn't lose signal on the out-of-phase image. So here's our in-phase image, axial image through the pelvis, and here's our out-of-phase image. The right iliac bone has normal marrow within it, and on the out-of-phase image you can see how it loses signal, and that's our tip-off that we're looking at a normal marrow pattern. On the left side we have a lesion in the left iliac bone, and on the out-of-phase image it does not lose signal the way the right side does, and that's our tip-off that there's no fat in that marrow and that this process is abnormal. So we bring ourselves back to the question, is this normal or abnormal, and how are we going to approach answering that question? For me, I think it's helpful to think about the various disease processes. What are the possibilities of what could be going on? And the kinds of things that we think of are marrow proliferative disorders, marrow replacement disorders, marrow depletion, vascular abnormalities, and then the things that don't fit into any category, the miscellaneous marrow disorders. So when we say myeloproliferative disorders, we're talking about abnormal proliferation of the usual hematopoietic elements that we find in marrow. These tend to be lower signal on T1. Their T2 signal is variable, but they're diffuse processes, right? These are elements that are in the marrow, and they affect the bone marrow diffusely. So multiple myeloma, leukemia, polycythemia vera, myelofibrosis, those are the kind of processes we're talking about there. And another kind of process that involves the marrow are marrow replacement disorders, where non-marrow cells are invading into the marrow. And these also tend to be iso or hypointense on T1 weighted images, more variable on T2 weighted images, usually high, and also focal, right? Something's coming into the marrow, it's coming into a focal space. And so these are things like osteomyelitis or benign primary bone tumor, metastasis, lymphoma, a primary malignant bone tumor. A third kind of process that can affect the marrow is marrow depletion, ablation, or failure of the red marrow element. So basically the red marrow has failed. All we have is fatty marrow. Here the signal intensity is going to follow fat. And these processes tend to be either diffuse or regional. Aplastic anemia, changes after radiation therapy, and sometimes changes after chemotherapy. This is a broad category, vascular abnormalities. What we're really referring to here is an edema, bone marrow edema-like pattern as a result of hyperemia or ischemia because of some process in the bone. So these processes tend to be high signal on T2-weighted images. They're often focal, often seen at the epiphysis. This is what we see in the setting of trauma, osteonecrosis, transient edema, and reactive edema in the setting of inflammatory arthritis. And then there are some processes that affect the marrow that don't fit into any of those categories, and these are some of the things that come in there. And we can talk about those individually. So it's helpful to know what the landscape is in terms of what can happen in the marrow, and now we're going to look at signal abnormalities. And we've already talked about this. This is a coronal T1-weighted image through the thighs, and here is, on the left side, normal marrow, a little hyperintense to the surrounding musculature. But on the right side, we can see that the marrow signal is actually hypointense, lower signal than the surrounding muscle, and that is the tumor infiltrating the bone. So the other thing we want to look at is the T2 signal. And many things are high signal on T2, but a smaller subset of processes are low signal, actually black looking on T2-weighted images. Focal lesions, bone islands, sclerotic vents, you're probably used to seeing those fairly commonly. And then diffuse processes like hemosiderosis, myelofibrosis, mastocytosis, osteopetrosis. And this is a case of hemosiderosis. So you can see low signal in the liver, low signal in the spleen, low T2 signal in the spine. All right, so we looked at signal intensity. The other way people approach these marrow processes is in terms of distribution. Is the process diffuse? Is it focal, or is it multifocal? And here we have an example of each of these: diffuse, focal, and multifocal. And so certain processes tend to be one or the other. Diffuse marrow processes could be the normal patterns we were looking at the very beginning, the marrow reconversion process in response to hypoxia, or the myeloproliferative diseases originating within the marrow. And this is an example of somebody with polycythemia vera. Focal processes, it's a long list of various things. This is just an example of discitis and osteomyelitis in the spine, infection, one of the things that can be focal in the marrow. And then multifocal processes like metastases, myeloma, and then any of the focal processes that turn out to be multifocal. So there, you can see there's overlap here. It's not an absolute, but it can help you think about things. The other, once you've gone through that process, then you're going to start looking somewhat desperately perhaps for special features that help drive a diagnosis. So looking for a fracture line, an insufficiency fracture in this case, in the distal femur, looking for changes related to osteonecrosis, avascular necrosis in the subchondral portion of a bone, looking for the characteristic pattern of a bone contusion. Our residents always see bone marrow edema and they call it a contusion. It's not always a contusion. You need the history, you need the characteristic pattern, but here is a characteristic pattern from a pivot shift trauma injury. And looking for soft tissue extension, as we see here, telling you that it's an aggressive process. Looking for the fracture line can be very important when you're evaluating a vertebral compression fracture. Oftentimes it's the radiologist who's confronting this, trying to decide, is this a benign compression fracture? Is this malignancy? What kind of workup is this patient going to need? And benign compression fractures usually involve the anterior column, that anterior waist deformity, but the posterior cortex is usually, the concavity is preserved. You can see it's a little bit concave. Sometimes these fractures involve the middle column, but benign compression fractures almost always have a fracture line, and that's what we're seeing here. A horizontal, low signal line surrounded by marrow edema in an acute setting that helps us decide that we're looking at a benign compression fracture. Contrast that with pathologic fractures, where the vertebral body is actually expanded. We've lost the concavity posteriorly. It's actually bulging. Malignant processes tend to involve the pedicles. They may have a soft tissue mass, and they don't tend to have a horizontal fracture line. What happens is that the malignancy fills the entire vertebral body, it destroys the trabeculae, the fracture happens late in the game, the trabeculae aren't there to form the fracture line. So that's something you're going to want to look for when you're looking at a vertebral body compression fracture. And then the other thing we look for are any other additional findings that can help with the diagnosis. So here we have coronal T1 weighted images through the thigh, we see abnormal signal in the distal femur, but you probably also observed that we've got an Erlenmeyer flask deformity here. And in the spine here, we see diffuse low T2 signal. So in this case, we've got our Erlenmeyer flask deformity. In this case, the patient also had an enlarged spleen. So on the right, we're looking at somebody with Gaucher's disease, and on the left, we're looking at somebody with myelofibrosis. All right, so continuing with our analysis, I would be remiss if I didn't say that it's very important to have the history, to have information about the labs, and to look at prior studies. Let's look at a few cases. Multiple myeloma is important to talk about because it's the most common primary bone malignancy, and people have described 4 different marrow patterns that you can see in multiple myeloma. Early on, it can be normal. You can get a focal form called plasmacytoma, and then later, in more advanced cases, there can be diffuse marrow signal abnormality or a micronodular or peppered kind of a pattern. And the diffuse form is relatively nonspecific, but people consider the peppered or micronodular pattern somewhat specific, and these patterns can coexist. I just wanted you to get a chance to see it. This is an example of the micronodular or peppered form on a T1 weighted image, and here it is on the fat saturated T2 weighted image, and here's the more diffuse form. So 2 different forms coexisting, but this pattern at least should raise the possibility of myeloma. Here is a patient with a different patient with polycythemia vera. This is one of the myeloproliferative processes representing clonal proliferation of red cell elements, and it's one of the diffuse processes. Here we see the patient early on in the course of their disease in 2009, and here they are much later in their disease, only 2 years later, but you can see how the marrow has been replaced by this process and how the person has converted from having marrow signal that is hyper-intense, brighter than the disc, to marrow signal that's lower signal than the disc on T1 weighted images, not very bright on T2, and so that's kind of a characteristic pattern. Lymphoma is another process you might come across relatively frequently. We actually saw this patient before when we saw the low signal in the femur. One of the characteristic features of lymphoma and other round cell diseases is that the soft tissue mass within the bone, the soft tissue abnormality of lymphoma in the bone actually permeates through intact cortex. So we see a large soft tissue mass, and yet the cortex is intact. That is a suggested feature for lymphoma or other round cell diseases. If you're involved in an institution that treats cancer patients, you're probably looking at patients who have post-radiation changes. And when marrow is treated with radiation, the red marrow is preferentially destroyed. This is a process with a relatively focal distribution, contiguous vertebrae or segment of the bone. The actual signal is going to depend on the dose of radiation and the time since the radiation, but one of the characteristic features is this abrupt margin. So an abrupt cutoff right at the edge of the radiation portal. So here, this marrow was treated with radiation and has lost the red marrow. We only see fatty marrow, and we see some edema in those vertebral bodies because it's still relatively recent. So the marrow appearance depends on the dose and the time interval. Basically, 2 to 6 weeks after radiation, the red marrow disappears. We convert over to fatty marrow by about 6 weeks. And then at 1 year, the appearance is going to depend on the radiation dose. If it's a relatively low dose, then the marrow can recover, and you'll see red marrow reappearing, normal red marrow, or at least some red marrow coming in. Sorry, at the higher doses, the marrow can never really recover, and you continue to see the fatty marrow pattern. This is one thing that you want to be aware of if you're looking at patients who are being treated, because these days patients who are getting chemo or have aplastic anemia may be treated with granulocyte colony stimulating factors, and this medication is meant to rev up their marrow, and it can mimic that reconversion process we were looking at, or a myeloproliferative disorder. And these changes can be very rapid and very striking, and really mimic a process. And it's important in this case to be aware of the history, the fact that they're being treated, so that you can appropriately interpret the images that you're looking at. So unfortunately I don't have time to really talk about some of the newer developments in terms of looking at marrow, but one point I wanted to make is that you can start to think about marrow as a biomarker for health and disease. And there are a lot of new techniques that are being explored now that are really helping us think about the biochemistry, the biomarker qualities of marrow. So diffusion imaging, looking at dynamic enhancement, and using these things to see response to disease, possibly prognosis, using MR spectroscopy to evaluate the various marrow processes. And this is just an example from the literature showing the use of whole body MR diffusion to look at this patient with myeloma and track their response by a change in their apparent diffusion coefficient. So next year when I come back, maybe this is something we can talk more about. So in summary, there's a wide range of normal marrow appearances. The presence of fat within the marrow can help to identify normal red marrow versus an infiltrative process in the marrow. You can use an analytic approach, understanding what the spectrum of marrow pathologies are, and looking at signal intensity and distribution, looking for characteristic features and any additional findings that can help. Obviously, reviewing the history and other imaging studies. You may not be able to arrive at a definitive diagnosis, but you can see how MR imaging would be very helpful in guiding biopsy to the area of maximal abnormality. And I hope I gave you an appreciation for what a dynamic tissue bone marrow is and how it might become a biomarker for disease and response to treatment. Thank you very much.